I'd like to introduce you to today's topic. If you would click advance me to the next slide, I have two left. Today's session is problematic sexual behaviors in children and adolescents. We have an incredible repeat presenter, Dr. Michael Gomez, who I will now present you with. So on the next slide, I'll tell you a little bit about Dr. Gomez, but I am so curious. Have you ever been to a Dr. Gomez session before with us? If so, at the bottom of your screen, you'll see a little reaction. It looks like a smiley face. If you hit that smiley face and click one of the icons, I'm always curious to know how many people have seen Dr. Gomez in action with us. There's a couple different topics that he has presented on. I was just curious to know. If so, hit a reaction. It'll kind of float across our screen. All right, so here's a little bit about our presenter. Oh, great. Look at, I knew it. He's a fan favorite. Dr. Michael Gomez has been a clinical instructor at Bradley Hospital, Lifespan Institute, and a teaching hospital for the Warren Alpert Medical School at Brown University. He was previously director of the Adversity and Resilience Community Center, ARC, a child trauma behavioral health clinic in Texas, where he also was an adjunct professor at Texas Tech University Psychological Sciences, the Texas Tech University College of Education, and the TTUHSC, that wasn't easy, School of Nursing. He was also previously faculty at the Center on Child Abuse and Neglect, Child Study Center Department of Developmental and Behavioral Pediatrics at the Oklahoma University Health and Sciences Center. Dr. Gomez specializes in trauma-focused CBT, treatment of adolescents with problematic sexual behaviors, PCIT, target, and assessment of autism spectrum disorders. He is a nationally certified TFCBT trainer and a nationally certified CE CERT trainer, a model for addressing burnout and vicarious trauma in providers. He's a co-founder of the National Child Traumatic Stress Network, Trauma and Intellectual and Developmental Disabilities, which is IDD work group, and so much more, y'all. So with that, I want to welcome to the virtual stage here, Dr. Michael Gomez, and say thank you so much for being with us. If you're as excited as I am to be here with Dr. Gomez today, why don't you give us a reaction at the bottom of your toolbar and give him a warm welcome. All right, Dr. Gomez, take it away.
All right, thank you, Jed. That's so nice. I thank everybody, and apologize for anyone who had to actually return back to hear me talk. No one should have to do that more than one time. So sorry that you upset your boss or had a reprimand. I apologize on that. And so I need to get Jess to do all my introductions, and because that sounds like I know what I'm doing. It sounds awesome, and so that's me. I do this, and as Jessica said, I am was formerly in a lot of different positions. Just as kind of a tech check too, I'm going to also let everyone know I'm going to come on and off the slides intentional. So hopefully that doesn't give you Zoom whiplash. But I will make sure that's why you have the actual slide deck there. Thank you, Dana, for providing that. And so Jess is right. I was formerly a clinical instructor. I was faculty at a place called Bradley Hospital in Providence, Rhode Island. Bradley is one of Brown University's teaching hospitals. I apologize. I am Brown. I was at a university, but it's the actual place in New England. So, and also like long walks on the beach, sunsets, and the smooth jazz stylings of John Coltrane. So, all right, folks. So today we're going to talk about all the horrible things that can happen to a kid. And to answer Herman's questions about a 2-hour training, it'll end at 11 Pacific. And Target, I'll talk about that in a little bit of the slides, but it's actually a model developed by Julian Ford, Beatrice. If you want to go on Amazon, you can get Hijacked by Your Brain by Dr. Julian Ford, and it describes the target model. It's a very short-term model for traumatic stress and transition age. And I'll reference some of the concepts here. So, and like, no way, Caitlin used to work at Bradley. Nice. Okay. San Diego has better weather, I promise. Also appreciate Carmen as a translator. Everyone give her a thumbs up, give her a warm welcome. Thank you, Carmen, for doing some very needed work for us. And so those of you who have not seen me present before, does anyone know what a Buffalo Wild Wings is? Anyone been to Buffalo Wild Wings? Okay, cool. If you haven't been to Buffalo Wild Wings, just like do a Google image search. That's what the inside of my head looks like all the time. It's like awful. There's a football game, a documentary on penguins, CW Supernatural. It's awful. So the slides will keep me a little bit more focused, but if my ADHD kicks in, I apologize to you as well as to Carmen, our translator. But we will go ahead and get started. And it's always on, Kelly. I'm sorry, Supernatural's constantly on. There we go. But it does help me monitor the chat box. However, if I miss a question or I miss something in the chat, Jess and Dana will catch it. So if I don't answer it immediately, I'll try to keep track of that as we're talking. But they'll make sure they get your questions. So we want this to be as interactive as possible. So, all right, since we're about to talk about all the horrific things that can happen to a child, we're going to look at the quokkas. And aren't the quokkas little? Aren't they so little? Look, they look like they exist off a diet of peanut butter and hugs, don't they? They're so cute, aren't they? And so what we're going to be doing today is talk about PSBs, how they're qualitatively different than pedophilia. They're usually seen as the same, they're very different. I also want you to know what to do, what not to do. And then I'm going to talk about specific things you can do like right this second, stuff you can take by the time this talk ends. Okay. But if it gets a little too heavy, just look at the quokkas. Look at them. Look at you. Just type that in right now. Just type that into like your Google Images and just have that up on your like laptop right now because they're so adorable, right? Um, do want to disclaim that I do not have any relevant financial relationship with any ineligible companies. Should anyone on this call wish to give me a relationship that would make me ineligible, I would gladly accept it. My job is just to sell out hard. Okay, I got a lot of student loans to pay. And if you know, like I've been trying to get Dunkin' Donuts to sponsor me, no dice, like 10 years, nothing. So if you know someone over at Dunkin', or I don't care where, like, it can be anywhere, just I need some, financial relationships to make me ineligible. So if you know that, just let me know. Now, Dana, I'm going to pass it to you. This is our first polling question, okay? And so I'm going to give our host a second or two to boot this up. But here's our polling question. What percentage of kids who sexually act out are abused in the age range of 6 to 18? Answer A will be 40%. B will be 60%. C will be 80%, and D will be 100. And so we have the polling question up now. Feel free to vote. We'll give you a second or two to answer that question. All right. Y'all are quick on the draw, folks. All right, we'll give everyone a couple more seconds. All right, got 60s and 80s. We're looking toe to toe for the winner. 100%. We get a few people usually ask that, a few who do 40. All right. And now have you closed the poll? All right. So we had about a couple of people say 40, most people saying 60 or 80, and a few saying 100. Do y'all want to know what the right answer is? A. A's, you have the answer. Okay. And so A's got the answer. This is also, as Jess said, on page 2 of the participant guide. So sometimes this is surprising to people. That is 40% maximum. That's the maximum we have, by the way. For 3, 4, 5 year olds, it goes up to about 60 to 70% of 3, 4, 5 year olds who sexually act out, who are abused. But that often surprises people that, the assumption is if you were sexually acting out, you must have been sexually abused, right? And that does happen. Not saying that never happens. Um, but if you look at the data, you take 100% of kids 6 to 18 who sexually act out, who have sexual behavior problems, what we will call PSB, problematic sexual behaviors. Um, and actually, Selena, we're kind of looking at other people. The thing that we would look if it's on themselves is if, at least in my role, a good example is problematic masturbation to the point of damaging the body. Like they have to go to the hospital. So we're really looking at like offenses on other people. And so, but that's a great clarification, Selena. And so take 100% of those kids, 6 to 18, maximum 40% have a trauma history. Um, Now, not all of that trauma, by the way, is sexual. So, like most things in the child maltreatment world, neglect takes the top spot. You type in unicorn on this thing right here, the third hit is pornography. So, mom is an addict, passed out, has an iPad for a babysitter. Kid eventually finds the pornographic material and then starts replicating it. Um, Domestic violence, IPV, is also a big culprit. People often don't think of it. as something that leads to problematic sexual behavior. But one of our PSB problematic sexual behavior trainers, Ben Siegel, over at University of Arkansas, did a study one time. And he what he looked in the study was coercive modeling versus sexual modeling. Um, sexual modeling would be kid walks in on mom and dad having sex. That's sexual modeling. Coercive modeling, kid walks in on dad beating the living crap out of mom. Okay. And he put them toe to toe to see what better predicts problematic sexual behaviors. I hope we can all agree to not show children pornography, okay, or sexual acts. If we cannot agree, then you have to stay after the call because we need to make a call on our side, okay? But if you put them toe to toe, IPV way better predicts sexual behavior problems than kids who have been sexually abused, which I wouldn't have thought about. Would you have thought about that? I would not have thought about that, but it makes total sense, doesn't it? Because what's rape? Rape isn't sex. Rape is coercion and dehumanization of another person. That's mine. Give it to me. And so, since the nucleus of rape is coercion and brutality, if that's modeled in a household and a family system, we also see a slight bump in problematic sexual behaviors in high levels of community violence. Um, and so we often see that there because of the same reason. So if we have coercion modeled, we have a bump. So like if, for example, Rosalind was one of our IPV shelter directors, I'd say, hey, Rosalind, you need to screen for PSBs for all your kids. And Rosalind would say, why? Then I'll tell her Dr. Siegel study. And she said, I'm doing that yesterday. And the percentage Rosalind for 3, 4, 5 is at the low end 60%, at the high end 70%. There's still some debate on that. Oh, and absolutely, showing kids pornography is considered abuse, Monica. That's 100% considered abuse. And but in my state, they may roll it out. I'm in Texas, so they might roll it out there. But the study was looking at what modeling, sexual modeling, like walking in on mom and dad having sex. Because we get some parents at our clinic saying, "My son saw me and my husband having sex. Is he going to have PSBs?" Nope. And actually, Monica, you might be in Texas because they said no to me too when I reported it. And so, but so parents worry about that, and we're saying, well, if we're looking at sexual modeling, like you walk in on mom and dad having sex versus coercive IPV, so that's the answer, Eleanor. So IPV predicts PSBs better than sexual modeling. Um, then we're going to be looking at the IPV. If there's violence in a relationship, we're much more concerned now about that. And so, man, they're learning some bad habits from Texas, Monica. So, but yeah, I made that call before too. Um, so, and again, that now people will ask me, well, if it's not sexual assault, what is it? And by the way, if you spent your entire career doing the following, I only work with sexually abused kids who sexually act out, and that's all you did for your career, you would be doing an amazing service. Thank you, CACs, Child Advocacy Centers, by the way. Okay. And IPV stands for interpersonal violence, Karen. It's a little more broad term for what we used to call DV. Um, and so, yeah, intimate partner violence. And so, um, but so that's not the only thing. So like we do have trauma kids, and I tend to work with those kids because I'm a trauma person. But the other two groups I see of kids who sexually act out, group number two are my IDD kids, intellectual developmental disability kids. Had a kid one time, 17 chronologically. He looked 35, man. This kid was like 6'3", 240. He was an Oklahoma farm boy. On a good day, cognitively, probably functioning at about a 7-year-old level, cognitively on a good day. Take one guess how old his victim was. Yeah, 7. Okay. They threw the book at this poor kid. He had no idea what was happening. ADHD, we often put in this bucket too. It's like, why did you touch that girl? I wasn't thinking. Yeah, because you have no executive functioning. You have no frontal lobe like that's going to stop you. So that's why I work a lot with kids with autism, intellectual disability, FAS. And so we see a higher spike in that just because they're not understanding the social cues. And the third group are my favorites, my delinquents. We caught you for the PSB, but you were dealing, you were truant, you were gang involved. So if anyone's familiar with the treatment multisystemic therapy, then that one is also a very powerful treatment for problematic sexual behaviors in teens, mainly for the delinquency bucket. The program I'm about to talk about called PSB CBT, and the treatment, Adrian, is multisystemic therapy, MST. Um, is it looks a little bit like multi-systemic therapy light, like the Diet Coke version of that. And so, um, and this, and actually, Isabel, we're going to hit that in the next slide. Good segue, Isabel. Thank you for that. And so the first thing I usually like to do, though, is since sexual abuse is so closely associated with this population, I like to go over what I call the sexual abuse myths. Can I get a thumbs up for my Law and Order SVU fans? Can I get a thumbs up? Okay, and the reactions. Who are my SVU fans? My people. Okay, I love Law and Order SVU. One, because they'll have a marathon for any reason. Law and Order Labor Day Marathon. The Law and Order It's Cloudy Outside Marathon. Law and Order Stabler Found a Hat Marathon. Um, and so um, that's it. And so I love it. And so um, the so but Law and Order, my favorite character on Law and Order. I don't know if anyone has a guess who my favorite character is. Ice T. Detective Finn Tutuola, my man, Ice T, because he treats each case like it's his first with complete confusion, complete absolute confusion. And so he has like, you mean this guy's into little kids? Like, yeah, Ice, I know you've been here for 12 years, but that's called a pedophile. And so the but my least favorite character is Dr. Wong. Okay, BD Wong. I call him Dr. Wrong because he's always wrong, by the way. Because he these are where all the myths come from. Like the medical exam ruled out it, like, no, Dr. Wong, you can't say that. Or like, because he was abused as a kid, he will be a rape. Like, no, he won't, Dr. Wong. The freaking data doesn't show. I really get upset with this guy. By the way, I hear that BD Wong, the actor, is just a lovely gentleman. He's a very lovely man. And so but I was in New York right before COVID hit, and I was very concerned that I would run into the actor BD Wong because the title of the news article would be Texas professor assaults actor, because I just that's what's going to happen, because I'm so upset at this guy because of his character, because I have to correct these. So medical exam always proves the abuse has occurred. It's false. It's a myth. Does anyone know in chat box what the statistically most common finding for a sexual assault nurse exam called the SANE exam, sexual assault nurse exam? Does anyone know what the most common finding is? Yeah, true. Circle is a square. Nicely done. Yeah. It's inconclusive. Nothing. Even rape by penetration. Okay. And I testify on this regularly, as does my mentor who taught me this, is that a child can be raped even with an instrument, and it can come out with nothing, with inconclusive. Okay? Um, by the way, if you think the kid has been abused, please still get the exam. We had a case in Oklahoma, 8-year-old little girl who had chlamydia, and there were 4 men we thought might have committed the offense. What would have been the logical thing to do, folks, in that case? What do you think they should have done in that case, given those circumstances? 8-year-old girl. Yeah, testament. What did they not do, folks, in that case? Yeah, testament. They didn't test them until we came up and said, please test these men for chlamydia. And their reaction at the DA's office was, you are the greatest legal mind we have ever encountered, Dr. Gomez. So like, dude, just please just test them. And I'm so done with this day. So please, we're not saying don't get it. Please get it. But if it's inconclusive, it doesn't mean nothing happened. Also, the child will have negative feelings towards the perpetrator. I don't know if anyone's recently read Maya Angelou's I Know Why the Cage Bird Sings. Has anyone recently read that? Anyone not have a girlfriend, can't get a date, no social life? Okay, just me. Great, wonderful, thanks. Well, in Maya Angelou's book, that's her trauma narrative, essentially. And she talks about her sexual assault. And she wasn't upset at this guy. She thought it was her boyfriend. And so she didn't have any negative feelings until the man said, if you tell your mother, I'll kill you. And she still didn't have negative feelings. She was really confused. Why would my boyfriend say something so weird? Right? We went over the third one. Like if they were abused, like if they're inappropriately acting out, if they have sexual behavior problems, and it's a Why the Cage Bird Sings, Stormy. Yeah, that book is heartbreaking, Lizzie. Now, if those of us who do a lot of trauma work, the nice thing about trauma screeners is you can always re-administer them. They're not like an IQ test. So if you think the kid is like just not feeling comfortable with you, just ask the question later down the road. But I'm guessing some people have had a case where the kid is sexually acting out and they say they don't have any abuse history, and you think they're telling the truth, but you might be getting pushed to find the abuse. And I would trust your gut. I would say, like, yeah, if you worst case, ask him later. He'll disclose later, or she'll disclose later. But don't we're not going to try to pressure them into a confession. Okay, again, we're not in Law and Order. Um, And by far the biggest one is children and adolescents who engage in this are pedophiles who are beyond help. That's by far the biggest myth. So I'm going to teach you how to address problematic sexual behaviors in literally less than 60 seconds. And I'm not joking and I'm not being facetious. Everybody ready? Okay. One thing my grandpa, this is my grandfather, Julian Escamilla. He was the first to cross the border in my family. He served in World War II to get citizenship, Pacific Theater, which they should rename because none of the good seats are at the front. But he said, anytime you come to a problem you don't understand, stop, go back, find any part you do understand, and start from there. So here we go. I'm going to teach you in less than 60 seconds how to address these. Ready? You never treat a sexual behavior problem. You treat a sexual behavior problem. Okay? I'll say that again. It's not a problematic sexual behavior. It's a problematic sexual behavior. These are behavior problems, not sexual, not what the DSM or ICD would call paraphilias. And so to give you a clinical illustration, I had a group of therapists in Tulsa, Oklahoma. They were doing consultation. We were in the middle of their year-long series of consultation. Really good school-based provider. She comes on the call talking. We're about we're call 6, basically, right halfway through. And this provider is panic talking, like, Dr. Gomez, I know what to do. And Dr. Gomez, you have, and Dr. Gomez, you do the sex stuff with the kids. Like, whoa, 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 whoa. Don't you say I do the sex stuff with the kids. Okay, you rephrase that now. Okay, you immediately, okay, say I do the sex stuff with the kids. That's creepy, man. As an aside, folks, when I got back to Texas from being in Oklahoma for 6 years, I thought I'd be the trauma guy because I do trauma therapy, right? First year I was there, 3 CPS workers said, send him to Dr. Gomez's sex. You know, where he does sex therapy? I'm like, will you stop seeing things like that? And yes, I know the goatee doesn't help. I get that. I'm aware of that. Okay. I'm just committed to it. So I tell this therapist, all right, players, slow your roll. What exactly happened? And here's what she says. Okay, the kid I've been working with, your 12-year-old, your 6th grader. Yeah. Walks up on the playground and fondles another student's breast. How old was the student? Another 6th grader. Okay. What happened immediately after? He laughed and ran away. Okay. So what's her question? By the way, here was her actual verbatim question. I I don't work with perps. I said, we're going to swing back to that. And we did. And I said, so your question is, you don't know how to address the PSB, problematic sexual behaviors. And her exact response was, yeah, I don't have the specialized training to do that. I said, okay. So let me give you another scenario. Same kid, same girl, same time of day, same school, same time. Everything's the same. I'm just going to change one factor in that scenario. Ready? Instead of walking up to this girl and fondling her breast, this little boy walks up, punches her right in the mouth, busts her nose, and there's blood everywhere. As a school-based provider, what would you do? And her reply is, he loses specials. He goes to ISS. He has to write an apology letter. No Xbox when he gets home. Sounds like a great plan. Do that. That's the plan. It's a behavior problem. Now, it's a very high intensity, very concerning behavior problem, but like breaking someone's nose, it's still a behavior problem at its nucleus. Now, I want you to give me a thumbs up if you on the call know how to deal with behavior. Now, you may not be great at it, but you know, like I know some of the fundamentals of how to deal with behavior problems. Thumbs up. Okay, great. Okay, now I want you to give me another thumbs up if you know. You don't have to know like Kohlberg or Piaget, but just give me a thumbs up. I know some basics about child development. Give me a thumbs up. Okay. All right. You just need those two. But I'm gonna do one or two others. Give me a thumbs up if you're familiar with CBT. Again, you don't need to be a master of CBT. You don't need to be at the Beck Institute. Okay. And then give me a thumbs up if you've ever worked with caregivers, worked with parents, foster parents, grandparents, teachers. All right. Congratulations. I have now knighted all of you as PSB, problematic sexual behavior interventionists. Congratulations. There you go. I don't know how to do that, actually. I'm going to be very honest with you. I don't know the exact method, but it's, something like that. That's it. That's really all you need. Good knowledge of behaviorism, behavior therapy, good knowledge of children, working development, like child development, like, egocentric, concrete stages. That's about all you need. CBT will help, not super necessary. And then, but working with caregivers, you really need to do that. You got those, you're good to go. Everything else we're about to talk about, just window dressing. Okay? You have the skills already in there. Though that's actually the specialized skills it takes to actually address this population. By the way, these kids make me look really good as a therapist. I'm not that good. Let's be honest. I'm like okay as a therapist. I'm not that great at it. But these kids, because I'm dealing with behavior problems, I've been doing that for 20 years. But did school based for 3.5 years. Did RTC for about three. Juvenile detention. Like I deal with behavior problems pretty much every day, and so I think so do you. So everything else just to make the process a little easier. That's what the rest of the talk's about. But those are the fundamentals you need. Okay, that's about it. Residential Treatment Center, Kelly, RTC, or Nightmare World for some of us who lived there for a while. So now, my grandpa would say you don't have to know everything, just where to find anything. So I'm going to show you where these are at and drop these in the chat box. But the first one I would recommend is National Center for Sexual Behavior of Youth. And if all you do while I'm talking is just go through that website, I'm cool with it. Jess and Dana will be very upset at you, but I'm cool with that. Okay, it's good use of time. National Child Traumatic Stress Network does have some good stuff. And I want to show you the Taking Action books. Okay, so here's NCSBY, National Center for Sexual Behavior of Youth. I'm going to drop that in the chat box, folks. And it has everything for if you're a caregiver, if you have a kid, an adolescent, if you have a kid who has been sexually acted on, impacted child, if you're a professional, you're military, you're tribal. We work a lot with tribal populations and tribal communities. And so so we have a ton of stuff. And if you're the actual youth who's engaged in this, NCTSN has a wonderful thing that they've done with the National Children's Alliance. It's very, simplified, easy kind of foot in the door of like how to get some more information about this population and what to do. I really like this resource, and they have some other ones. My graduate students who are my supervisees have to read these two books. This is the red one.
Michael, you're on mute.
Sorry about that. All apologies. But so this red book is written by Dr. James Solowski, our current director at Oklahoma, also the developer of the PSB CBT school age and preschool group. And so she and problematic sexual behavior, cognitive behavior therapy groups. It's free, 80. Right here, just a free PDF download. That's why I have it right here. The adolescent one, it's a blue cover. I think they're doing maintenance on the site right now, but it's also free. If you really, really want a pretty copy, you can go down all the way here and get the pretty copy, the paper copy. But it's completely free. And this is the blue one is what we give our teens. The Dr. Bonner, the developer of the teen model, PSB CBT adolescent, is the one who wrote it. So all my trainees have to read the red book and the blue book before I write their letter of recommendation, because it has all your basics. The biggest difference between blue and red is there's a lot more kind of legalese stuff in blue, and also and yes, Selena, you can definitely download it for free, both of these. Okay. You should be able to if you have trouble downloading it, just contact Safer Society. Say sometimes there's some trouble with some individual like iOSs, but they usually can solve it. So these are my kind of go-to resources. There's a lot of others we'll go over in a second, but these are the ones I want you to have in your back pocket. Now, even though I just said that most of these kids have not been traumatized, please screen for trauma. As a trauma person, I'm not a fan of universal trauma therapy, but I am a fan of universal trauma screening. ACEs study, if nothing else. Sexual abuse is a reason, but not the reason. Again, IPV, intimate partner violence, things like that, neglect. So we're looking at everything. Okay. Now, if you don't have a trauma screener, oops, sorry, wrong slide. Accessing trauma screener. You can go to this website, Oklahoma TFCBT. Go here to resources. And all right. And so here we go. This has all our stuff. This is our trauma focused CBT website. If you like, I need a trauma screener. What do? Go to assessment, go to the CATS2 Child Adolescent Trauma Screener, and you'll get the webinar. You get you can take the webinar. It's a YouTube link. Here's the example. Here's the handout. Here's a guide. Here's the caregiver version, the youth version. You got everything there. And so if you like, if this is your thing, by the way, like, I do trauma screening all the time. Cool. Then, use what you got, UCLA, CPSS, all these other measures, but this is the one I usually like to give you. So I'd say still always screen for trauma. Those of you playing along at home, we are on page 3 of your participant guide. And coercive behavior is more predictive of sexual acting out than really any other factor that we're finding, because we think the core of sexual assault is coercion, it's dehumanization, it's brutality, it's cruelty. It's not sex. That's not the core of sexual assault. It's much more horrible things. Horrible things. Now, a while back, Dr. Solowski at our Oklahoma site did a 10-year follow-up for kids, like how safe are these kids? And we found that even without treatment, they often don't act out. Just like even without intervention, kids who are like fighting may stop after high school. But it ups the rate. Instead of 1 in 50, which is the 2% for the PSB CBT, it ups it to like 1 in 10. So the risk is increased without treatment, but with basic treatment, like we just talked about, behavior therapy, CBT, these kids are very safe. Second polling question. Okay, I'll pass it to you, Dana. Teens, we'll stick with teens because it's easy for me to convince you a 6-year-old is not a pedophile. 16's a harder sell. Teens who sexually act out, not preteens, need to be treated in an inpatient setting. True, we'll do a true false this time. Always mom. Best friend in college. True false, what you think? All right, give folks a second or two. All right, give everybody another second or two. Y'all are doing an amazing job participating. Thank y'all, folks. Y'all are such a wonderful audience. All right. Okay, does everyone want the answer? Y'all are learning, y'all are quick learners. It's false. Okay. Um, completely false. Okay. Again, those of you playing along, we are still on the participant guide. One thing I usually like to talk about is I work a lot with teens because, again, 6-year-old, me convincing you a 6-year-old is not a pedophile, I can probably do that. 16 is a little bit more difficult to convince people. And I get it because they're scarier. Also, they have a lot of acne and they smell like Axe body spray, which is a smell of desperation. It's just disgusting. Just a bunch of boys with Axe body spray. Like, you need to wash, dude. Okay. Though, like, it doesn't cover it. Now it just smells like Axe BO is all it smells like. That's really all we're doing. But and so, oh yeah, oh, and you're getting ahead of the story, Adrian. So you're getting ahead. And so we're gonna actually going to get there too, Adrian. And so, but if you're wondering, because I'm referencing the Oklahoma program, University of Oklahoma Health Sciences Center, where I learned pretty much all of this. If you're wondering how a crimson state like Oklahoma got the state of Oklahoma to pay year after year for over decades for adolescent boys who sexually act out and not just throw them in jail, it's because our fearless leader, Dr. Barbara Bonner, um, convinced the state that you can incarcerate them. It's pretty pricey, right? I just want y'all to kind of, reflect in the chat on yours particular state. Y'all have a bunch of beds open. You're just like, oh, we have so many beds open in our state. We have, like juvenile detention is like so empty right now. Yeah, not Oklahoma either. And so she said, you can do this all outpatient safely and much more cheaply and save hundreds of thousands of registered voters' dollars every year. And that's how she got this program rolled out in one of the most crimson states in the union. That's how. And because we're just more effective than incarcerating them or doing inpatient work. One of the things I usually talk about, especially if you're coming from the trauma world like I was, is because if you're doing child trauma, you're working with CPS and sometimes law enforcement. If you're doing PSB, problematic sexual behavior work, you're working with law enforcement and sometimes child welfare. And so, and actually, Helen, the answer to your question, it depends on the state. That's really the answer. That's really the answer because some states have, like in the state of Oklahoma, it is 100% legal for a 16-year-old person to consent to sex with a 66-year-old person. That is actually legal. North Carolina, no, it isn't. That's illegal. And so, oh, I think, yeah, and actually we're getting to that one too, Emma, is that, yes, we do see a disproportionate number of BIPOC kids in our incarceration. Like that, we get a lot of BIPOC kids because they just throw them in there, right? They don't do a deferral. They just throw them straight in juvie. But since I'm working a lot with cops in this neck of the woods, I a lot of them are military, or they at least understand the idea of levels of force. And so I say, okay, officer, should you, not do you, should you draw your firearm, like all things being equal? Like, no, first we got to do a verbal warning, then a physical, then we have, like pepper spray, then we have like, yeah, you have levels of response. So essentially what you're doing with a lot of these kids is you're pulling out your firearm, which is the lock security. You have nowhere else to go if that doesn't work. Um, by the way, as just some self-disclosure, my alma mater is juvenile detention. Go Honey Badgers. And I said, speaking both professionally and from experience, all juvenile detention does is make you a better criminal. That's all it does, man. It's like grad school for criminals, man. Like you just learn how to be better, con man, better drug dealer. Like that's all I learned, dude. And so you have nowhere else to go. So let's try this, because your worst case scenario is our program outpatient craps out, it wasn't effective, and you can always send them to inpatient. They really like that idea because they're like, we don't have a bed to send them, we don't have a cell to send them to. It's all full in Oklahoma. Yeah, give us a couple weeks, couple months till you figure it out. And often they're doing much better by that point in time. And so this is often, if you're talking especially to shareholders, or talking to officers, lawyers, DA's offices, this is really helpful for them to understand, like, hey, if you just want to go with cold money, we're cheaper, man. Uh, we just really are. And so those of you playing along at home, Dr. Slawski is actually redoing this meta-analysis. It's a little dated at this point, but what she found that worked with kids who sexually act out is basically what we talked about, behavior therapy. And also adding some stuff in which is in the Taking Action books on Oklahoma TSCBT, on NCSBY, the websites I just showed you, like boundaries, sex education, abuse prevention. Here's the thing that did not work: anything based in old school adult pedophilia models. And now they're trying to make some headway in the adult pedophile world. First by changing the language. If you want to see some stuff that it looks pretty decent, I would go to ATSA's, the Association for Treatment of Sexual Abusers. That's one. Please don't type in pedophile on your computer, or else you're going to get a call from HR. Okay, that'll keep you safe. Okay, that'll keep you out of HR. But short version is, when I was doing this training, like when I was training to do this work, I had to sit in on adult pedophile groups, and here's what they look like. Ready? It looks like AA, and I'm not knocking AA or NA. I think they're wonderful organizations, but here's what they look like. There's a moderator, and there's like 12 men. All right, John, go ahead and stand up. All right, my name is John Smith. I'm a 44-year-old Caucasian male. In 2018, I raped 2 4-year-old girls. That's it. He tells a story. They go to Alan, then they go to Bobby, and that's it. And actually, thank you, Angelica. That's kind of my talk. Is like, AA is supposed to be support, not like an evidence-based treatment. They don't identify as that. And so, and again, PSB, problematic sexual behavior. And so, um, when I walked out of those groups, it just felt kind of gross. And so, anything also, hopefully no one knows the following term of penile straps or chemical castration. I apologize if you do have to know what those terms are, because I actually have to know. They're horrible things that are still being done across the U.S. Because they're seeing these kids as they cannot be rehabilitated. They're monsters. Okay. A lot of people, and I'll pause for just a second, because some people ask me, "Hey, dude, you do trauma work?" And I'm also very upfront with my own history of lived experience as a child trauma survivor. I lead from that perspective. Nothing about us without us, right? And so people say, dude, how did you get into this work? Because that's the last place we'd expect someone like you to be, which I would agree with that. If you'd asked me 15 years ago, not only am I going to be doing this stuff, working PSBs, problematic sexual behaviors, but teaching this and training people to do this, I would have told you you're out of your mind. Here's how I got into it. The Barbara Bonner, who I mentioned, one of the developers for the protocol in Oklahoma, for the adolescents, I was on internship. And this is January of, oh my God, it was January 2010. Okay, give me a second. I'm just processing how old I am. Just give me 2 seconds. It's hitting me right now. Okay, midlife crisis. But basically, I had done one of the other rotations, and I was done with it at the halfway mark. Other students had the rest of the year. And she said, hey, Michael, we're down a therapist and a teen, a PSB group. Would you like to join? Because you work a lot with teens. And I cannot believe I said this to my mentor. I said, Barbara, I don't work with perps. And Barbara Bonner had a very Barbara Bonner reply. She went, well, give it a try. That's how she talks, by the way. She's lovely. And I still remember that first group because I did this group for 6 years at Oklahoma. It's burned into my hardware, by the way. Every Wednesday, 3 to 4, prep check-in. 4 to 5:30 group, 5:30 to 6:30, staffing notes. We're done. Graduation is on every odd number month, January, March, May. First Wednesday, it's always Wednesday. That's always the time. So I remember the group, if you ever in Oklahoma City, we have the Child Study Center where most of us have our offices and we do therapy in. And then across the street is the Nicholson Towers, it's a conference center. We have the adolescent group in that location in the Nicholson Towers. People often assume it's a safety. Well, these are teens and they're violent and they're dangerous and they're pedophiles. That is not the reason. Here's the reason. The teen group, there are 2 boys groups. We do single gender, boy or female, male or female. Um, 2 boys groups, max out at 15, plus the 2 therapists, plus the parents group. But there could be literally 60 bodies. We just can't house them in the child study center. And so the way you get there is you cross the street, go up an elevator to the 5th floor, and there's like this 100-yard hallway you walk down. I still remember that walk because here's what I'm thinking: the first group I ever did. Gonna go, gonna make Barbara happy, gonna bounce. I don't work with perps. These are rapists. These are perps. These are pedophiles. Lock them in a box and throw the box in the ocean, man. F them. I don't care about them. I'm a sexual assault survivor. They can go. I don't care where they go. That was my thought. I don't remember what we talked about that night. Youngest guy was 13. Oldest guy was 17. The only thing that went through my head for 90 minutes was the following. These are kids. These are just kids. I was never more ashamed of myself than in any moment. I am not saying if you have that reaction that that makes you a bad person or that you should feel shame. I am not saying that. It just didn't feel right for me. It felt wrong. And I had to fix it. At my drive home, I'm like, I got to make this right. I can't let this stand. This cannot be the thing that stands. I have to make this right. And the way I thought to make it right is I dedicated a chunk of my career to working with these youth. I found it extremely rewarding. I really have. It's been some of the most rewarding work of my life. But and especially in statistically on this call, there's going to be those of us who have a high ACE score, and one of those ACEs is going to be sexual assault. So I really get that. I'm not saying you have to do this work, but what hit me was I threw away a whole group of kids. I didn't even blink. Did you catch that? I didn't even blink when I did that. I just threw them away. And so there's so many misconceptions that we have about this population, about these youth. They can be safe. They can go back. To normal. They can be integrated in the community. They can have good lives and be safe. And they did a horrible, horrible thing, but they're not evil. I've never said that's not what I've seen in my work. But that's what I assumed. But that's how I actually got into this. That's why I got into this is because of that. Because I was operating off of these antiquated assumptions. And thankfully, the team at Oklahoma was wonderful about helping me get through those. So now this one is a thank you, Hassan. Is not what you're not. So like if, for example, like we have, Beatrice doesn't, do like, sexual health education for a kid with it. I'm not gonna like call out Beatrice. This is just what we got asked this at a training um, one time about like, well, what about expected play, inappropriate but not illegal, and then illegal? And me and my co-partner Jimmy Whitfield, this is what we talked about. So we kind of set it up in this. This is kind of the way our brain thinks at Oklahoma. Your brain doesn't have to think the same way, and so, but it sometimes people find this helpful. Like, no, Michael, you've been doing this for a minute. How would you think through these scenarios? And this is how I would think through these scenarios. I'm not saying this is like the thing you have to do. If you do something that's different than this, then you're doing something horrible. I'm just saying like this is kind of how my brain thinks, basically, in like kind of this XY format. So for example, we do think that all kids should have sexual health information. I apologize. I grew up in Texas where sex doesn't occur. Sex never has happened in the state of Texas. I don't know how people are reproduced. It just doesn't happen. But maybe in your state it does. So I would highly recommend that, and just in case, I still do it here in Texas. Um, And educating youth about healthy sexual behavior, we still think is a good idea. Safety planning, maybe not for expected, but probably for the others. Um, Understanding the effects, like it doesn't kind of make sense for sexual, but if you did that, that's fine. For the others, it does. We have done very brief treatment for kids who had expected sexual play. It wasn't coercive, it wasn't inappropriate, but we've done like 5 sessions of like just what I'm going to show you, like general information, like coping skills. For illegal with our teens are in there for a year. Our school age are in there for about 4 to 5 months, and our preschools are in there for about 3 months. So the bigger kids, bigger problems. But that's just our style. It's not saying that if you work with a teen less than a year, you're doing something horrible. And so again, that's just how my brain works. Okay. Now, this is an article that Dr. Brian Allen had published. And here's the short version. I'm going to show this article real quick. Come here, little buddy. Not you. I gotta find it real quick. And so there we go. Just use right there. That's what I needed. Okay. Brian put like 70 articles in one article. Thank you, Brian, for it, because all of our stuff was just dispersed across all these random journals. And this gives you the basics, a lot of stuff we've been talking about. But honestly, if you're TFCBT trained, which is now the only evidence-based model for abused kids who have sexual behavior problems, you can just go to the table, kind of gives you the cliff notes. Right. It breaks down a lot of this in the article, but this is really kind of the cliff notes. If you're TFCBT trained, right now, this is the only evidence-based treatment that has peer-reviewed data that it works for this population of problematic sexual behavior kids. And so that's why I share this particular article. I think it's a really good one. Okay. And thank you, Brian, for making life easier for everyone else out there, because we were just like, we all had the 70 articles. If you work with adolescents, I would highly advise you getting the other article on complex trauma. That one should have been included too in your packet. But Brian's article gets you what you need here. So these are the two like peer-reviewed articles I would for sure get, is Brian's in the article, and it should be Herman in the training notes. Now, because what I'm going to do is I'm going to kind of go through how that evidence-based treatment, TFCBT, and like how CBT looks for these kids. Okay. And so we're going to go through these components of psychoeducation, relaxation, affect, and coping. And we're going to spend our time looking at actual concrete skills that we can use for these kids. Okay. We've been talking a lot about concepts and about kind of these ideas. So I want to give you some actual concrete stuff, because I'm kind of a concrete person and I kind of need concrete things for stuff to make sense to me. So hopefully this will be helpful. Okay. So psychoeducation, horrible name for basically just information. It's a verb, not a noun. Okay. It's not like who won the Battle of Gettysburg. It's how do you change a flat tire? And so we divide between our littles, like our preteens and our teens. So we often start with like body education, right? Private parts. Does anyone know why we never ever use good touch, bad touch? We use safe, unsafe, or okay, not okay. Does anyone know why we never use good touch, bad touch? Yeah, the actress is on fire today, man. She was a dagger from the three. Yeah, some bad touches can feel good, right, Angie? And some good touches for our traumatized kids can feel bad. Like some of my kids are given like a pat on the back, which is technically a good touch, and it freaks them out because they have complex trauma. And so we want to take the value judgment out of it. Now with our adolescents, I'll show you a diagram of how we do this, like these 4 squares. So I'm going to start breaking these down right this second. Okay, we're going to break all these down. Okay. So if this is the direct like bullet points we give our caregivers and teachers if they see sexual behavior. So first we got to define, is it normative? So please be in your frontal lobe, not in your amygdala. That's our biggest advice for caregivers. Amygdalas can only fight, flight, freeze, or fawn. They have no other options. Amygdalas are not bad. Amygdalas can only like have those 4. So I need you in your prefrontal cortex. So we gotta calm you down. With my teens, teen parents, I tell them to take a parent timeout, because often parents of teens will punish themselves, right? It's like, Erica, you are grounded, young lady. I don't care. For a week, Erica. I don't care. A month, Erica. I don't care. 2. And then Erica's mom is like, I don't like Erica. I gotta stay home with her 2 months. This sucks, right? Yeah, mom just like punished herself. Erica's fine. She's gonna be on her phone. She's cool. She's good to go. And so, yeah, she's going to be fine after about a week. And so, and also my mom, my Mexicana mom, my Mexican mom was never, when she was yelling, everything was cool. I was fine. When my mom got quiet, it was terrifying because here's what my mom sounded like when she got quiet. Michael Daniel, I'm going to go into my room, mijito, and I'm going to think of your consequence, and I will return in precisely 1 hour. And I'm like, I'm dead. I'm gonna die. They're gonna find my body in a day because my mom's gonna kill because like she was never more Michael Corleone uh than like see how she had the mojito, Kelly, right? She added that in. It's like, oh, I'm dead, man. I'm so freaking dead now. And so yeah, get calm. Stop it if it's still in progress, and then we want you to respond like basically a teaching mode. So we for appropriate names for the body, developmentally social rules. The social rules and the boundaries allow you to add in cultural components because medically it may not be a problem, but culturally or your race or religion, yeah, it might be a problem for that particular denomination or that particular ethnic background. So it allows us to like have some nuance in there that respects culture, respects race, ethnicity, gender, religion. We want to make sure that we my phrase to parents is I'm never going to dictate your values, but I'm going to support them unless they're abusive early. Now, for PSBs, still the same steps. Get them calm, stop the behavior, get them safe. Then again, I tell parents if they say, Dr. Gomez, my kid was touching my other kid's private parts. Okay. First, we need to check. Do we need to do a report? We probably don't, especially with our younger kids. But I'd say, how would you handle this if you walked in on your son punching your daughter? Okay. I stop the behavior. I get my daughter safe. Then I go over, hey, this is just, you broke a rule, man. You're losing your free time. Consequence if needed and increase visual supervision. That's the money. We've got to increase. We can't just like leave them at home. You'd be surprised how many times that happens. Now, these private part roles, the preschool and school age, I'm going to show you where to access them. You can access them here on this website, on this slide deck, but I'm also going to go back to Oklahoma TFCBT. There we go. We're going to go all the way to the bottom. Again, this is the one I put in the chat box a second ago. I'll put it in the chat box again right this second. There we go. Sexual behaviors. Now, this is mainly for our preteens. So our preschool private part roles, this will be like 3, 4, 5, maybe 6. No touching other people's private parts. No other people touching your private parts. No showing private parts to other people, and no looking. Okay. And these are just standing house rules. Those of you who do parent work, this is just a house rule, like no hitting, no running, no spitting. Okay. For our school age, there used to be 4. But you see, they're slightly different. No, it's not okay to look at other people's breasts, not okay to show them. Like we also give them the exception for like physicians or nurses. Okay, we give them that exception, obviously. Um, we did have a really funny scenario where a kid went to the doctor after it was like a week after we taught him this and told the doctor, "You're breaking a private part." Just started screaming, "You breaking a private part rule to this physician," which I thought was very funny, but the physician did not find that amusing even a little bit. Okay, and so but we taught him the rule. He followed the rule. It's not okay to touch other people's. Number 4 is our masturbation rule. If there's like, for example, a religious prohibition, you can X that. These are not written stone. You can get that out. But if I've had cases where the only thing they're coming in is for problematic masturbation. That's the only thing they're coming in for. And so they're like, you can't talk about masturbation. Well, then I can't do my job. It's kind of like saying, Dr. Gomez, I need the entire budget for this fiscal year, but don't give me any numbers. Okay, that's impossible to do. Okay. Now, you see these last 2, not okay to use your sexual language and not okay to make other people uncomfortable with your sexual behavior. These were added for a specific kid in our school age group because this kid talked like Amy Schumer. And I love Schumer. I love Amy Schumer. But man, this kid was rough. And yeah, 80, this is on the Oklahoma TFCBT website. I'll put this one in the chat box right now for our school age. But you can get these. These are publicly accessible. You don't have to pay a fee. So the next week, this kid came back to group. Congrats, bud. You got 2 rules. He was so upset, by the way. He's like, what? Yeah, we can add rules. We're doctors. We can do whatever we want, man. And so there you go. Because he was following all the other ones, but man, the stuff that came out of his mouth, and he was like humping the chair. Dude, this is rough, man. This is like a little crazy, man. And so that's what we had to do. Now, implicit in that for our littles, here's our kind of algorithm. That's kind of what we want to end on. We start with the following. We're going to do things like like boundaries. Okay, not okay touch. So like breaking a private part rule is a not okay touch. Also, punching is a not okay touch. Spitting is a not okay touch, right? Um, if you go to my actual physical center here in West Texas, you'll see a bunch of hula hoops because with like our 3-4-year-olds, we'll do hula space. And it's like, okay, so um, 80, the rules for hula space are you can ask permission to come into someone's hula space, but if they say no, you can't get mad. Those of you who work with children with autism, you can wait 15 minutes to ask again. If not, then here's what 80's gonna do. Can I give a hug, Mr. Anthony? No, 80. Thank you for asking. Can I get a hug, Mr. Anthony? No, 80. Thank you for asking. Can I get a hug? It's 80, 15-minute timer, and then you can ask Mr. Morales again, okay? Right? You make sure to do that with your kids with like autism, FAS, things like that. Um, and then we practice that. That's our session, right? So hula space, one of my therapists, the Circle of Grace, right? She works at like a parochial school. Then we do private parts. What's this? That's called a head. What's this called? That's called a nose. What are these called on girls? Breast, vagina, penis, buttocks. If you're working on private parts with tween boys, after you say what I just said, say, okay, keep laughing. Keep laughing, Herman. You're not laughing enough, Herman. I need you to laugh more. Like get the giggles out. It's fine. Okay. And then we can go to private part rules. So we have to do this okay, not okay touch, boundary like hula space, right? You can do other stuff, what the names are, and it has to be anatomically correct. This isn't just a PSB reason, it's also a trauma reason. One of the kids we had at our center, right, Emma, get the giggles out. This little 5-year-old girl went, her teacher said, "What did you do this weekend, sweetheart?" "Daddy watered my flower." And she said, that's awesome. Now, hopefully, if she had said, "Daddy put his penis in my vagina," there would have been a different reaction from the teacher. But kids have all these cutesy names for private parts, like my ooh ooh. What is an ooh ooh? I've never heard of an ooh ooh. I don't even know what that is. And so we want the anatomically correct terms. And then we can move to things like private part rules. Like you can see how this is for like elementary kids, things like that. Now, I've gotten the question of what if the parent doesn't want you to talk about sex? And I've had that. I have had, maximum 5% of parents say, Miss Peterson, do not talk to my boy about sex, Miss Peterson. You do not talk to him about sex, man. Cool. Like again, if you're trying to get me to do the budget without using numbers, it's going to be kind of hard. I've had that 95% of the time. Here's what you're going to really get. So Emma, you're going to talk to my son about, you're going to do that, Emma? You're going to talk to him about sex. Is that right, Emma? And Emma's reply to Mr. Gomez is, "Mr. Gomez, I would never take away your honor and privilege to have such a formative conversation with your child." Okay, I get paid enough, man, to do this. Okay, now I do work with people like nurses. They have a sexual health educator background, so they love this conversation. Cool. Even if you have that background and you love having this conversation, I still want you to make the parents learn this. And here's why. Because you're not going to be there 24/7. The parent is, the caregiver is, the grandparent, the foster parent, the teacher, like whoever is their primary adult person, they're going to be there more just chronologically than you are. So the way we do this is I'll teach the caregiver this stuff, and then they teach the kid in the session or in the contact, like if you're working like school based or something. Um, and I tell, by the way, here's the wrong way to approach a caregiver. "Hey, Laura, you don't know anything about sex because your sex ed suck, right?" Okay, that's the wrong way. Here's the right way. "Hey, Miss Thomas, look, I'll just level with you, Miss Thomas. I'm from Texas, yeah, spent a lot of time, grew up there. The sex ed was awful. So just so we make sure that everybody's on the same page, I'm gonna teach you what I'm gonna talk to your daughter about. And again, the idea is I'll teach it to you, I'll be in the room coaching you, but you're gonna be having the conversation. We are not a fan of the talk. The talk traumatized a bunch of us as children, and so we're not a fan of it. We're a fan of micro talks along the lifespan. So the younger you start, the more micro talks, but the less likely you are to have a big talk. So like when the kid's taking a bath, "What's that?" Right? Parents know that, right? It's like, "That's called a penis." "Why doesn't Sissy have one?" "She has a vagina." You're done. That's your conversation. You're done for the moment. You'll have another one, maybe a couple of weeks, in a month, and that's fine. And so, but if like I work with teens, so a lot of parents have never had this, so it takes a lot of prep, and often they have to have one long conversation with us helping, and then they can have the micro conversations, especially with that. But if you have, especially parents, most of my parents have multiple kids. Um, I want to make sure that you teach them what's called the sheriff's deputy role. And here's what I mean by the sheriff's deputy role. Only answer the question posed to you by the child, no more, no less. Here's why. Had a mom, 15-year-old boy in our adolescent PSB group. There was a 5-year-old daughter, 5-year-old sibling. He had nothing to do. There was no inappropriate behavior between the two siblings. The offense was on a same age peer at school. That's why he was in our program. But we tell mom, she's a single mom, is like, there's no dad, dad's incarcerated, so you're gonna have the sex talk. And mom's eyes were like huge. And it's like, we will help you with it. It took us 4 weeks to get her enough information to talk to the teen about. And she nailed the landing. She did great. Okay. I was running parents group at that time. I did 3 years boys group, 3 years parents. She comes back next week to parents group and tells the group, I think I broke my child's brain, her 5-year-old. And we're like, what did you do to your little girl? And so, short version, those of you who are parents, especially those of you who have parents with your parents of younger children or have been parents of younger children, you can't get distracted, right? So she said, I was washing the dishes. The daughter comes in like from the back, like from the like that direction. Mom's washing dishes. And here's what her little 5-year-old says. Mommy, where do babies come from? Mom goes into the 15-year-old version that we prepped her on for a month. Penis is inserted in the vagina. It ejaculates semen. She starts doing that. She says, I did that for like a minute or two, and then I stopped cold. I turn around, and my little 5-year-old's face is white as a sheet. And the girl's like, I just wanted to know if it came out your belly button. And she's like, I traumatized her. She's gonna be broken forever. And she's mom is like, this is a catastrophe. And I said, okay, mom, first thing, that's hilarious. And we all start laughing. He said, second thing, she's going to be the coolest adult that we've ever met. And she was. I was proven right. She just got accepted to the Peace Corps. Um, so let's talk about the third thing, sheriff's deputy role. Okay. So Peter gets pulled over by a sheriff's deputy. Every license and registration, ma'am? Yes, sir. You know how fast you're going, Miss Brown? No, sir. That's how she's going to talk to that deputy. Okay. Take two. Mommy, where do babies come from? What exactly do you want to know, Corazon? They come out your belly button? No, they do not need. Do you have any other questions? No. Right? That's a 5-year-old, right? Those of you who have 5-year-olds or work with 5-year-olds, that's all they really want. It's like those random questions, right? They don't need the whole insemination and the gestation. They don't need that conversation. And so, yeah, and thank you, Emma, for dropping that in the chat box too, the porn conversation. It's really just like they need the content and they need to like get calm. They need to be in their frontal lobe. And I'll always tell parents, it's okay to say you don't know or say, hey, let me find out about that. I actually don't know that. Because it's a conversation, right? We do the same thing, by the way, with death and dying. We add tiny micro conversations along the lifespan. Sex and death. That's why we have jobs as therapists, by the way. So we want to make sure that, especially with our preteens, we're getting these basic information like okay, not okay, boundaries, through the space, private parts, private part rules, and these micro conversations. And that's kind of what our big focus is on there. We don't think this should just be done with kids who have problematic sexual behaviors or sexual assault history. We think every kid could benefit from this. But again, I grew up in Texas where sex doesn't exist. It's never actually happened in the state. So, but if it happens in your state, I would highly encourage you to do that. Okay? All right. And then again, these are just a repetition of the school age one that you saw. Now, from CBT, oh, that's a good one too, Zoe, the Scarlet team. And so, yeah, and I would say, yeah, I was going to say, I think it's for older. Like I've seen it done in college too. You'll be probably, not you, Zoe, you'll be shocked that some other people that, yeah, they don't get a lot of this stuff in college. And again, we want to establish these private part rules. We want this it's a very behavioral kind of plan. And we want a safety plan, especially for our older kids. But most importantly, supervision. That's the foundation of everything we do here. That's it. Okay. It's basically just everything you've seen, like from parent-child interaction therapy, child-parent psychotherapy, parent management training, all these protocols all have this two-phase model of attachment, child-directed, and parent-directed consequences. We want to focus on attachment because that's the core for parent-child relationships. We got to focus on that first. I say that like a lot of the behavioral techniques we have don't address PTSD or PSBs or GAD or DMDD. They address MUFD. Is everyone familiar with that diagnostic MUFD, messed up family disorder, or FUFD, depending on the day or the family you've encountered? Okay. Yeah. So you know you have MUFD when like the kid like walks in and you're like, yo, man, like Anthony, why are you here in my office, Anthony? You're kind of witty, you're sarcastic. I dig that, man. You're athletic, dude. Why are you here, man? And then Anthony's bio parents walk in. We're like, copy that, man. You didn't stand a chance, did you, kid? Like need like a parent transplant, Anthony. And so yeah, and so we want. It took me a long time to believe this, and I believe it now. I didn't believe it when I was first told it, but I really do believe this is parents aren't the problem, they're the solution. I'll say it again. Parents are not the problem, they're the solution. Caregivers are not the problem, they're the solution. I didn't believe that when I was first told that by a mentor, but I believe it now. And I'll give you an illustration. Uh, so, um, messed up family disorder, Marisa. So, I'm just being me, basically. We had a dad. This dad's son had done some legitimately messed up stuff. Like he was a, um, it was rape, basically. And so I apologize. That's my dog protecting me from the postman. And in his defense, the postman has never successfully assaulted me. Yeah. But only trainers can do the intakes because it's a very sensitive spot for entry point for our kids, especially our teens. And basically, when a parent comes to group, we do introductions when there's a new parent. So this guy's intake was on a Monday. Wednesday is when our group is. So this guy, he's in the middle. He's directly facing me. So we start like, okay, let's go ahead and introduce ourselves. My name's Amanda. My son is Sean. He's in group one. He's here for Ludax. Okay, and then we keep going. Here's what we do when we get to this gentleman, right? He's brand new. This is day one in group week one. Ready? Here's what he does. My name is John. My son is Adam. He raped somebody. Okay, moving on. So I was like, that was his intro. We get the second to last person. The way our adolescent group works is it's an open group. Open group means that everyone starts differently and everyone finishes differently. Closed group means everyone would start the same time and end the same time. And so he's day one. The second to last parent is month 11. They're about to be done. So, and I did his intake too. So, second to last parent says, "Everyone, my name's William. My son is Arnold. He's a group leader of group two. He's here for rape two." And then he stops and he looks right at John. He goes, "Look, John, brother, you don't have to say anything, man. I just want you to know I literally sat in the same chair you did when I was here my first day. And I get it, man. I hated everyone and everything. I hated CPS. I hated the state of Oklahoma. I hated Dr. Gomez. I'm sitting right here. We cool, but I hated you. I hated OU. I hated the JPOs. I hated everybody. But look, man, give it a shot, man. Try this, man. This program works. It gets you out. My son's about to graduate. He's gonna go to college, man. He's gonna be an attorney. Like he's a good kid, man. He can do, and how powerful that is, right? Like that's what the caregiver is saying. It's like, yeah, thank you, right, Michaela? Like the power of the group space, right? And it's like, yeah, and the guy he did really well. But because those of you who work with trauma populations like I do, can those parents talk to just anybody about what happened to their kid? No. Okay, now amp that to 11 because not only and some of our parents, my kid was sexually abused by my own son. Who do I talk to? They're isolated. They feel shame. They feel like they effed up, right? Um, that same caregiver, that second to last caregiver, I remember with graduation, he said, I really thought I failed my family as a man because this happened. And you guys taught me I didn't, man. I was like, well put, my friend, well put. Um, and so I really, especially working with kids, working with cases, like doing work like this, caregivers are really the solution, not the problem. I really do believe that it is. It took me a while though. So this is just for your information. You don't need to memorize this stuff. I just wanted you to have this on your slide so you at least have some check boxes. Because when I'm done talking, you'll be like, what the heck did he say about supervision? Um, so like it has to be visual for a lot of our kids. Like they can't just like go to the store and come back and say they supervise them. Sometimes we do have to get very creative. Like, we have to have like schedules for who's in the room, who's in the bathroom, who does showers. So some of this becomes like very logistic very quickly, especially if you have multiple kids. Um, my adolescents always get this wrong. So Billy, if your mother said, "Can you babysit your 6-year-old cousin?" Would you do it? Yeah, I would help them out. Wrong answer. And they'd be like, "Well, I'm not going to do it again. I know what's right, I know what's wrong." Well, I'm not saying you don't, man. I'm saying imagine it from just like the legal perspective. Your 6-year-old kid says some 6-year-old cousin says something happened. Who are they going to believe, man? So this isn't just to protect your cousins, protect everybody. We want everybody to be safe and everyone to have protection. And it's rare that the adolescents are doing this. Usually more common the caregivers are giving them the supervision. And again, some of this may like kind of smash into cultural norms. When it happens, because like we work a lot with tribal countries and tribal, lands, and they'll say, no, this is normal for our tribe for the oldest sibling to do the babysitting. I say, well, for the next 3 months, we have to find another plan. This isn't a permanent thing, but for the next 90 days, the courts are going to be looking at this very stringently. So we need to find another way, and they usually do once we explain that to them. Um, and so um, there actually is, if anyone's interested, a Native American application for the Oklahoma Problematic Sexual Behavior CBT program. And so I think it's called um, like Respectful Ways, I believe. And so we do have this cross culturally adapted for other cultures. Um, Again, this is just for your information. We're not going to spend a ton of time on this. It's just more like, are you thinking these through? Are the caregivers? And I often with these slides, I just go through, say, again, these seem very simple, but you would be very surprised how many people. We had one dad who he just liked action movies, and so there was all this like R-rated movies playing, and we're like, dude, you can't. I'm sorry, you can't watch like that. It has a lot of nudity, man. I know it's a cop movie, but like, no, man. And he got it. He just didn't think that that was an issue. We're like, no, we really need to, be very mindful of this for especially the first couple of months of treatment. Now, for my teens, we're talking about preteens. Teens are a little bit harder, but I like working with them. These are the questions I make sure caregivers ask once they're able to kind of like they're, if they're not on house arrest, they don't have the ankle jewelry. Um, okay, who will be there? These are also just good questions to ask if you have a teenager, by the way. Um, who'll be there? Do I know them? When will you be back? What adults will be supervising you? Those of you who are parents and have teens, admittedly, just to self-disclose, I do not have any of my own children to my knowledge, but I have a lot of friends who do, and I work with kids, and so I usually tell my friends because their kids are now switching to teen, and I say, here's the difference between preteens and teens. Everybody ready? Preteens are puppies. Teenagers are cats. That's the difference, right? You're not losing your kid and they didn't become a different person. They went from a dog to a cat. Okay. Because those of you who have like young kids or who have had young kids like 7 or 8, hey mom, hey mom, hey mom, hey mom, mijito, cálmate. I'm like, I can't like, and yes, over here, I will show that slide again momentarily. But yeah, they can't wait, right? Versus your teens. Thank you, Dana, for dropping that in. Here's what your teen looks like, right? Um, Hey, mijito, how was school today? Fine. Are you okay? Go to school? Yeah. Anything happen? Would you like to talk? Okay, I'm going to just make dinner, mijito. Mom, 4 seconds ago, I asked. I didn't want to talk 4 seconds ago. I want to talk now. Right? That's all your teenagers, right, Isabella? Every teen like, and so you didn't lose your mind, and they didn't lose theirs technically. They're just become by the way, it does resolve when they hit 33. Okay. By that time for sure. Only 20 years of this stuff. Okay, parents, not even a big deal. And over here, here's the slide too. But again, and again, this is in your slide deck. I just give parents like make sure you got answers to all these questions. It may sound like an interrogation, but these are really the questions we need to know before we're going to let you go somewhere. Um, and because in our program, it's not enough that you don't sexually reoffend. You have to be doing there. You can't be gang involved. You can't be truant. You have to be, passing your classes. I got an LD. Get your school psych eval done. Um, and so, yeah. And so, talking about parents. Oh, sorry. Just looking at your question, Selena. Talking to the parents of those homes. Oh yeah, the parents are like our programs. we don't do the treatment one-on-one with the kid ever. The caregiver has to be present. That's a requirement because we can't fix it without them. There's 168 hours in the week. We would see them it doesn't make any sense to try to fix them in an hour when 167 are unaccounted for. And yeah, good question, Selena. This goes into the next thing we're going to talk about, which is this is what you can see this is a little bit more complicated than our preteen one. And so actually, Adrian, go mom style for sure. Which friends, what family will be there? One of the first things we do, kind of for Selena's question in the chat box, is we talk about who to tell. Because here's the wrong way that gets done, especially at school. Selena's a teacher at one of my kids' high schools. Hey, Billy, where do you go every Wednesday? Your mom takes you out early. Where are you going, bud? Miss Alvarez, legally, I don't have to say anything to you, Miss Alvarez. Which is true, but everyone who's worked in the school, Selena's going to find out, right? So we got to prep the kid. And the default answer when they don't know is to say, hey, Miss Alvarez, it's something I got to do with my mom. She said you got to ask her. Right. So they go to the friend's home, say like, well, he had, you can say like he's in legal trouble. What legal trouble? We don't feel comfortable talking about that. And the friends can say, well, I don't want him over my house. Okay, that's fair. Like, yeah, you're going to have certain restrictions given that you're now in legal trouble, right? Given that you did illegal behavior, did something that, warranted like the justice system coming in. And so these are the conversations we want to have before. So, kind of to go back to the previous slide, we don't want to do this as we're walking out the door. I know that sounds really obvious, but apparently it's not. So we want to do this like way in advance. The one advantage you have with teens versus preteens is preteens, you got a consequence right that second, or your 5-year-old has no idea why you're upset. And so yeah. Oh yeah, and I got the clean version too, and Allison for that one. Yeah, so we want to make sure that we do this like way in advance because the teens can prospect, even though they might not like to. So now, before I show the T video, and Allison's right, there's a clean and not clean. I got the clean version on this one. I think I do. We get a lot of things like this. Miss Mata, he needs to learn respect and he needs to learn, values. And it's like, okay, cool. Mr. Gomez, I agree with you that your son does need to learn respect and value and all that stuff. That's way up here at the top. The rule of this diagram is you can't do the higher level work if you don't have the bottom layers, covered. They don't have to be mastered, but you at least got to cover them. So if your kid doesn't know anything about consent, they don't know anything about STIs and sexual health, they don't know anything about emotional safety, how are they going to learn what respect is, which is at the very top? And so the biggest thing for teens, we talk about consent. That's really the biggest task in the bottom one. And so for that one, I'm going to show you the video. We call this the T video, consent T video. Come here, little buddy. There we go. Okay. Come here, little guy. I got you. All right. And Jess, if this starts lagging, you let me know, and then we'll switch to your version. Okay. All right. So, and this, I'm going to show you in real time. Everybody ready? Okay. Here we go. All right.
If you're still struggling with consent, just imagine instead of initiating sex, you're making them a cup of tea. You say, hey, would you like a cup of tea? And they go, oh my God, I would love a cup of tea, thank you. Then you know they want a cup of tea. If you say, hey, would you like a cup of tea? And they're like, I'm not really sure. Then you can make them a cup of tea, or not, but be aware that they might not drink it. And if they don't drink it, then, and this is the important bit, don't make them drink it. Just because you made it doesn't mean you're entitled to watch them drink it. And if they say, no thank you, then don't make them tea. At all. Just don't make them tea. Don't make them drink tea, don't get annoyed at them for not wanting tea. They just don't want tea, okay? They might say, yes please, that's kind of you. And then when the tea arrives, they actually don't want the tea at all. Sure, that's kind of annoying as you've gone to all the effort of making the tea, but they remain under no obligation to drink the tea. They did want tea, now they don't. Some people change their mind in the time it takes to boil the kettle, brew the tea, and add the milk. And it's okay for people to change their mind, and you are still not entitled to watch them drink it. And if they're unconscious, don't make them tea. Unconscious people don't want tea, and they can't answer the question, do you want tea? Because they're unconscious. Okay, maybe they were conscious when you asked them if they wanted tea, and they said yes, but in the time it took you to boil the kettle or brew the tea and add the milk, they are now unconscious. You should just put the tea down, make sure the unconscious person is safe, and this is the important part again, don't make them drink the tea. They said yes then, sure, but unconscious people don't want tea. If someone said yes to tea, started drinking it, and then passed out before they'd finished it, don't keep on pouring it down their throat. Take the tea away. Make sure they are safe, because unconscious people don't want tea. Trust me on this. If someone said yes to tea around your house last Saturday, that doesn't mean they want you to make them tea all the time. They don't want you to come around to their place unexpectedly and make them tea and force them to drink it, going, but you wanted tea last week, or to wake up to find you pouring tea down their throat, going, but you wanted tea last night. If you can understand how completely ludicrous it is to force people to have tea when they don't want tea, and you are able to understand when people don't want tea, then how hard is it to understand when it comes to sex? Whether it's tea or sex, consent is everything. And on that note, I'm going to make myself a cup of tea.
So that is the consent tea video. I will put that in the chat box, the English version. If someone can find the Spanish one, please plop that in there. That last part where he says, I think I'm going to go have myself a cup of tea. I showed that to one of my 16-year-old boys. And I said, okay, what's your first thought going through your head after seeing that video, man? And he thought for about a good 30 seconds, and he goes, so does that mean he's going to masturbate? Dude, is that all you got from this video? Like, I just want, like, all right, we're watching it again. Watching the whole thing again. You're going to have a different answer. It's wrong answer. That was all he got. And so, yeah, so I showed that to the kid, to the caregiver, that we talk about that. I think it's probably the easiest way to explain consent. I do that for all my tweens and teens, regardless of sexual assault history, problematic sexual behavior history. Thank you. That's right, Alyssa. I know a lot of adult men who need this video. And so a lot of people need this video. And so, and that's again the core of pretty much every sexual assault statute we have in the United States is consent, lack of consent specifically. So that's why you can see we spend a lot of time hitting that with a sledgehammer. Then we go to physical safety. Things like STI, sexual health, Planned Parenthood has some great resources. There's a ton of these. Yeah, Herman, I show the youngest kid I show with is 10. Just in part because our world is getting darker. And oddly, that 10-year-old, the caregiver requested it. She's like, can we go over things like consent? And so, and I was like, yeah, we for sure can. And so I always clear with the caregiver, because again, I really do want the caregiver running the ball on this. There's some other stuff. Trevor Project has some amazing stuff as well here. And John Oliver last week tonight, out of nowhere, has an amazing sex health episode on it's on abstinence. So good. Reason we cover this and we spend time on this is I'm going to give you a survey of teenage boys in our Oklahoma group, their sexual health knowledge. Everybody ready? You can get rid of AIDS. Magic Johnson has AIDS and he's fine. And if you get a girl pregnant, give her Mountain Dew because of the yellow dye, guys. You get it, the yellow dye. And I told this kid, dude, stop messing around. He goes, no, it's true, Dr. Gomez, the yellow dye. And I said, who told you that? My cousin. Your cousin's an idiot. That's who he is. And so, yeah, and please, yeah, feel free in the chat box to put the ones you use. Like Love is Respect. Like there's a ton of great stuff out there. These are just kind of like off the top of my head. Then we do relationship safety, which I'm going to do on the next slide. And then we do values and beliefs. And if the sexual health one kind of, upset me about my teens, I was like really disappointed in them. Like, dude, I cannot believe this is the state of your knowledge about sexual health. Then the values one really endeared them, because I remember the same kid who said like Mountain Dew gets rid of pregnancies, that kid, when we got here, we were talking about monogamy, polygamy, things like that. And this is what this boy says. He goes, yo, man, I think if I had a wife, I'd never cheat on her, man, because my mom got cheated on by my dad and it broke her. I'm like, dude, really? And I was like, that's such a beautiful thing. You're like a 15-year-old guy to say, man. Thank you, Allison, for putting that in there. Yeah, that one just stood out. I thought he did an amazing job with it. And so I was shocked that I didn't expect that level of information on that show. Like it made sense. I mean, he did a great job. Now, emotional safety, I do this with every teen and tween I work with. I'm going to do it in real time. And so here's how we're going to do that. Okay. The steps are outlined here. So I'm not going to verbally go over the steps. These are for your information. But I'm going to show you in real time how I do this. Okay. So there's a lot of text here, but I'm going to go over it in real time to kind of show you exactly what it looks like. Okay. Oops, sorry about that. So everybody ready? Okay. So let's say that I have 15-year-old Jessica. Okay. Now, 15-year-old Jessica. And the only thing my teens really have a lot of energy for is relationships. That's what they have. That's their money. Okay. So I will go. We start at the endpoints. Little buddy. All right. So I start with red light relationships. Okay. And so I'll say, so Jessica, we're going to go over stoplight relationships. People aren't red, yellow, or green. Behaviors are. Okay. And so the first behavior we're going to go over, these are going to be red light relationship behaviors. So an example of a red light relationship behavior, Jessica, is any physical violence. But what if any physical violence, Jessica? Okay. And it'll be like any cheating, Jessica. But what if any cheating, Jessica? Sorry, kid. These are brute facts of the universe. You're just gonna have to go with me. I'm sorry for this activity. And if Jessica, like, okay, can you guess some other ones if those are red? And Jessica, if she can't, I can feed them. But if she can't, make you do illegal stuff. Yeah, that's a great example of a red light behavior, Jessica. Good job. Okay. And I stay here as long as Jessica needs. Okay. Again, I'm doing the very fast version just for sake of time. Then I go to the polar opposite with green. And if Jessica can't get these, then I can just feed them to her. But if she can, I'll say, so Jessica, if those are red, what are green? Not cheating. Yeah, being faithful. Okay. That's a great example. And then I start again. If Jessica can't get these, that's okay. I can I can feed them to her. So, but I'm gonna give it a shot. Like, so give me some other green ones, Jessica. Compliments. Yeah. Okay, we'll do compliments. Let me get here. Compliments. Trust, being honest, and I'll let Jessica stay here for a little bit of time because I'm trying to get to the middle. The middle one is our yellow. We're gonna spend some time here. The easiest middle one that I have as an example for teaching my teens and tweens is passive aggressiveness. Oh my God, Addie, I love how you just wear anything. The hell does that mean, man? Passive aggressive freaking kids. What I'm really trying to get to is John Gottman's work. Thumbs up if anyone here is a John Gottman fan. Anyone knows Dr. Gottman's stuff? His stuff is amazing. Great. God bless our marriage and family therapists, because I would make a horrific marriage therapist or couples therapist. Like, oh my God, like you've been with him 5 years, I've been with him 5 minutes. He sounds like a jerk. You must be a saint. That'd be me as a couples therapist. And I know my strengths and I know my weaknesses. So thank God for Dr. Gottman and his team. He goes over something called the 4 horsemen. The 4 horsemen are, we steal directly from John Gottman's work. 7 principles of a healthy marriage is a great entry point. The relationship cure, great. He has very readable stuff. So let's say Jessica is heteronormative, cisgender female, and she has a boyfriend named Adam. Okay. So I'll say, so Jessica, let's say today, Tuesday, you walk up to Adam, you see something's going on, and you say, hey, babe, what's going on? I'm going to go through each one. Basically, as they get higher, Jessica, they get more toxic, meaning 4 is more toxic than 1, 2, 3 put together. You ready? Here's the first horseman. Okay. Stonewalling. Hey, babe, are you okay, Adam? Cool. All right, you got that one, Jessica? Okay, we're going to go to the next one. Defensiveness. Hey, Adam, is everything okay? You look like something's wrong. Look, Jess, why do you always something have to be wrong with me? Why are you always trying to tell me what my life is like? Okay, see how they're getting worse, Jess? Next one is critical. Hey, babe, are you okay? You look like something's wrong. Look, I may not be as perfect as you, Jessica, and you may be like the perfect person. You think I'm not doing well. You always like to hit. Right? See, I'm getting worse, Jess. And the worst one, contempt. This is worse than 1, 2, 3 put together, Jessica. Contempt is defined as hatred plus disgust. Ready? Take 4. Hey, Adam, are you all right? Is everything cool? Oh no, I'm perfect, Jessica, just like you are. Damn, that's nasty, ain't it? Okay, that's ugly. And so, and usually at this point, my session is kind of done. And so, like I'm usually at the top of my session. So I do what's called a circles of contact. Um, and the way a circles of contact work is I'll put one, two, three. It's just like three circles on a sheet of paper. And my kids have to basically, you know, draw. So to let you know, the circles are, this one are people like acquaintances, like people I know, people I'm like cool with. And this circle is ride or die. Okay. That's who they call the inner circle. And you'd be surprised, like a lot of their like greens are way out here. So next week I'd say, hey Jess, who's this person? That's Dana. You don't like Dana? No, she's cool. She's in algebra with me. So why don't you hang out with Dana? She's one of those honor roll kids. She's like so smart. Okay. Your trauma's showing, Jess. All their reds and yellows are here. Hey, just tell me who's this person, Jess? Oh, that's like 80. That's my girl. Why is she red? She's my drug dealer. Okay, cool. Always 420 at 80's house, you know? Uh, and so that's what I call a circle of contact. Okay. And I'm not judging, I'm just trying to get kind of who's who. The very next thing I do is go over what I call the exchange rate. So I say, today is Tuesday, Jess. Let's say tomorrow, Wednesday, you walk up to Adam. Adam already has one yellow on his record. He has an option. He can go this way. And if you come up tomorrow and you say, hey, Adam, babe, you bit my freaking head off. What is your deal, man? He could say, hey, Jess, I'm sorry. That was jacked up. I shouldn't have said anything. That was meant. I'm so sorry. That's really nice of Adam to do, Jessica, but it's not 1-to-1. It's 1-to-10. For every one yellow, you need 10 greens to undo it. Gottman says 1-to-4, 1-to-5. I have teenagers, so I have to double the number. Okay. And Adam can't do that again, Jessica. On the other hand, so like he has 1 - 1, so he needs 9 more. Okay. On the other hand, Adam could decide to go this way. Yo, Jess, I said I'm fine. Why you always up in my grill about? So now he needs 20. He does it again, he needs 30. And I don't know if you've seen a yellow that looks orange, because the exchange rate for oranges are 1-to-50. And maybe you've seen an orange that looks so dark it might as well be red. Because here is the most important lesson we have, Jessica. The exchange rate for reds are 1-to-infinity. No amount of greens undo a red. Because you know the old saying, right, Jess? Once a cheater, he will change the second he says he's sorry. You know that old saying, right, Jessica? Okay. And so the last thing I do with a kid, that's called the exchange rate. That is in your slides. Is a rule that every year fewer and fewer people get this rule, and it makes me sad. And the rule is, I call it the Janet Jackson rule. Okay, what have you done for me lately, girl? So, because a lot of my kids are trafficked, so their traffickers are really green the first month or two, then get really crimson real quick. So I'm like, well, he's really nice. Adam's nice. Just what's he done for you lately, girl? He got me a great birthday present. Jessica, your birthday is in September. Okay. What has he done? I'll give you all of June and July. Give you 2 months. What's he done for you lately, girl? Okay. And because we usually, my kids will, focus on that, and they won't see all the big warning signs. Admittedly, my kids do what I tend to do in romantic relationships, which is take those red flags down, paint them green, and hoist them right back up. It's like, yeah, Anthony, every girl has 5 burner phones. That's just women, right, Anthony? Michael, no, man. No, we got to talk. Yeah, every girl knows every bartender in a 50-mile radius, right, Anthony? That's just women these days, right, Anthony? Gomez, dude, we got to sit down, man. You can't go out unsupervised, man. This is scary for me right now, man. I'm your friend. Uh, now, I did this with a kid with autism. This is a 10-year-old kid with autism. And he took this very little, he got the scorecard. We were trying to show him that his friends, quote unquote, Johnny and Sam, were actually abusing him. They were victimizing him, but because he's proximal to them, he thought, well, they're with me, so they must be my friends. When we introduced this technique, he kept the score. We didn't make him do this. He did this all on his own. This was adorable. And so that's right, Emma. And so, by the way, this boyfriends, This kid is not LGBTQ. Mom was adorable when we put boyfriend, because mom says I hang out with my girlfriends. He has autism. He hangs out with his boyfriends, right? Mom. So it had nothing to do with LGBTQ. But mom's approach was just the funniest thing. She's like, okay, look, if he is, I'm not, it's not bad. I support it. I'm an ally, but I like, mom, he just means male friend. That's actually what he meant. And she's like, it'd be okay. She was like so nervous, and she was like trying to struggle with like his like identity, which he wasn't. He was just like, no, just boyfriends. My mom says girlfriends. But we found Adam gave him a Valentine's Day card because he didn't have any Valentine's Day cards. No one gave him one. He said, that's one green. So Adam is actually my true friend. He like took this and ran like hell with it. I was so proud of this kid. And so now, for sake of time, I'm going to skip a couple of slides. So I do want to leave some time for questions. Y'all have been doing wonderful. We still want to do like relaxation techniques. I do want to show you the emotions sheet that Dr. Schmidt, one of my mentors and one of the person who runs the PSP program at OU now, it's basically a cognitive triangle. So she starts with a feeling, then the reaction, like there must be a mistake. My kid wouldn't do this. And then the corrective information. This is often a good way for providers to think through how to talk to a caregiver. It's like, what's the feeling they're having? How is it coming out? Like, what are they saying? And then what's the corrective information we need to give them, right? And you can bullet point it. Well, like this is, this is an example that we have this isn't what you have to do, but it's kind of how to think through this, right? The beating heart of our program in Oklahoma is this cognitive triangle. This is it. Okay. Think, feel, act. You drop a pebble into any one part of the pond, it ripples to the other. Those of you playing along at home can use your participant guide. And it doesn't have to be a geometric triangle. What I want to show you right now is the one we use for our teens. I would use this for like a 10-year-old. This is about appropriate for a 10-year-old. There's a lot of really good resources on CBT if you're not familiar with them. And so come here, little buddy. All right. So in our curricula, this is how we teach this to our teen boys. First, we teach them the what we call ABCs, antecedent behavior consequence. Okay. And so think, feel, act is the B. Then we give them the scenario and we fill it in for them. We just do it for them. Top, it didn't go well. Bottom, it went a little bit better. And we're not saying that thinking is superior to feeling or behaving. We're just saying, can you really just not punch someone if you're this pissed off? If you're this pissed off, can you be happy all of a sudden without drugs? No. So the only door number 1 and 2 are closed. We got door number 3. And really important part, anytime you're doing CBT with a kid or doing this kind of process, for the bad one, the top one, any bad behavior, you have to start with the positive consequences, not the negative. Because here's what happens if you start with the negative. Herman, what's the bad thing about fighting someone? Nothing. I like fighting people. We're done with Herman's triangle. We're all done. But if I say, hey, Herman, what did you get out of punching this guy? What was a good thing? He'll look at me first like I lost my mind, but I'm dead serious. It's like, they may not mess with me. Yeah, dude. Yeah. What else, Herman? Feels good. Yeah, dude, have you ever punched someone you don't like, man? If they can make that a drug, that'd be the new crack. It feels amazingly good. Not that I've ever done that ever in my life. I've never done that. But because they're teens, they usually exhaust these pretty quickly. And then so we go to the other side. So what's the negative consequence? I'll get in trouble. Sorry, Herman, you are not a qualitative thinker. You're a quantitative thinker, my friend. You're a teenager. Your frontal lobe isn't fully developed. So we have to help them with that. Because if they could do this on their own, they wouldn't need therapy. They wouldn't need us. They'd be good to go, right? So like you got 2 positives, but you got like 5 negatives. So if this was a football game, you lost, man. And then so we go to the bottom, and we have to help them a lot with this. Like we have to really structure this with them. Oh yeah, Jolene, the ABCs are on that Oklahoma TSBT website under cognitive coping. And again, I don't need you to like say, oh, it's not like, nothing happened. Like, yeah, it was an accident. They often forget under feelings that they think, well, I need to be happy. No, being mad at a 9 and being mad at a 3 is a big difference. There's a difference between a cluster headache and a headache. And they often forget that not doing anything is a behavior. And so Or the bottom one, for any good behavior, you have to start with possible negative consequences for 2 reasons. Ready? Have you ever done the right thing and got screwed over for it? Yeah, so have they. Okay, so you do the right thing, turns out crappy. That's life, right? So we want to at least validate that. The other reason is, let's say I say, so Herman, what happens if you just ignore that kid? I get jumped at 4:30. Oh crap, man, I thought I was doing CBT. I'm actually doing a safety plan. I'm sorry, man, I didn't know that. I'm sorry. So now I know I have to keep Herman safe. Okay? And often they don't know that the positive consequences are things that didn't happen. You didn't get suspended. You didn't lose your Xbox. You didn't go back to jail. And so this is a muscle. We have to build this muscle. It's like cardio. So we fill this whole thing out. Then I remove the consequences and they fill them out. Then we do a couple of these sheets. Then the consequences and behaviors and they fill them out. Then the consequences behave so I keep progressively removing, starting from the right side, going to the left until they get this sheet and they can fill it all in. This is muscle building. This is more learning how to run a marathon than it is like learning how to build a bookcase. Okay. Very last thing, and I apologize for skipping some slides just for sake of time. I want to go to the very last thing. Okay, polling question number 3. To effectively treat PSBs, you have to talk about the offense in great depth. True or false, folks? All right, folks. All right, nicely done. And a lot of good answers. All right. Close it out there. Yeah, good job. All right, folks, the falses have it. Only in our teen program do we actually talk about the sexual offense. In our school age and preschool, we don't have to. It's again, it's a behavior problem. You don't have to talk about like fighting to like get it resolved. It's not hurtful. It just isn't the thing that resolves it. Again, it's a behavior problem. Here's also why this is a little dicey. And not only am I saying you don't have to do this with kids, you might, especially with complex trauma people, you might want to actively avoid it. Here's why. With trauma work, in trauma therapy, our job is to get them to this happy middle, this little minion. Okay, we don't want them numb. We don't want them having a panic attack. We want them suffering the slings and arrows of outrageous fortune, not avoiding them. Okay, so the goal is desensitization for most trauma. Okay, now when we do this with our later adolescents, we rarely do it with preteens. This is really for later adolescents. The goal, we call it a disclosure, a restitution. The goal is to sensitize them. Because a lot of my kids are saying like, yo, Miss Madley, she kind of asked for it. So we got to kick you up the scale. But one of my kids, what he told me was that he was graduating. Complex trauma is what CT is, Anthony. Yeah, or CPTSD is another way to say that. He basically said that if he hadn't gotten better, he would have killed himself. I'm like, dude, I don't want you dead, man. That's not what we want here. So here's the very last thing I want to go over. There's a study we did in Alabama in a place called MIGS. MIGS is where the state of Alabama puts their violent adolescent male sex offenders. 98% have with trauma that is no before. They were literally born into trauma. We think the other 2% are lying. This article is now a TFCBT study. The original study was 3 conditions. TFCBT first, and then we'll do PSB work, trauma-focused CBT. Then we'll do problematic sexual behavior work. Condition 2, well, they're offenders. Let's give them offender treatment. Let's do problematic sexual behavior, and then we'll do trauma therapy. And condition 3 was control. So condition 1, kids were doing great. Trauma therapy first before we do, quote, offender treatment. Condition 3, control, no change. Condition 2, where we did, quote, offender treatment. We dysregulated these kids. They were suicidal. They were head banging. We had no idea what to do. So I flew to Alabama for a month. I was there for like a straight month. Here's what we found out. People who have complex trauma don't go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 on that scale I showed you. They go 1, 2, 10. So when we did a confrontational sensitization model, they went from, yo, it's not a big deal, Miss Matley, to, I raped 4 girls. I'm the devil. I should die. We pendulum them. That's what we did. So now our PAT recommendation, our standard operating procedure is in the presence of a traumatized individual who also has problematic sexual behaviors, just start trauma therapy. Just do trauma stuff. Because a lot of the stuff you just saw, like sexual health, private part rules, we can integrate that real easily in something like trauma-focused CBT or parent-child interaction therapy, right? It's easy to integrate. But our kind of more fundamental reason is, how can you have compassion for someone else if you hate yourself? You think you're a piece of crap. You think you're worthless and nothing, right? Imagine an apology, kind of like someone who says they're sorry. If they think they're worthless and a piece of crap, that's kind of not an apology, right? So the short version is, you can't have compassion for others unless you have a little for yourself. These kids hated themselves. They thought they were damaged and dirty and worthless, and no one wants me. And my mom hates me. My dad tried to kill me. And yeah, man. So let's do the healing inside before we can do reparation, restitution, whatever your term for it is. Before you can take accountability and responsibility, you have to have some compassion. So you got to lead from compassion. I know that sounds real simple, but apparently it took an entire university and a state initiative to find out we got to lead from compassion. And then I felt so horrible about those boys in the second condition. I apologized to every one of them. And they were like, "It's cool, Dr. Go." Like, no, it's not cool, man. We had an IRB review. We like made sure that this never going to happen again. Like, we want to make sure our kids are safe. You did a horrible thing, but you don't deserve to die, buddy. You don't. We're going to get you back to your life. And so last slide is, this is just a summary slide. Again, we want to be with like, well, he sexually abused, so it's okay. He's sexually acting out, he's a pedophile. Both of those are wrong. It's a behavior problem, not a sexual problem. Things with behavior therapy, a CBT nucleus, those are what we're looking for. Adult pedophile treatments really are ineffective or harmful at worst. And with complex trauma, I'd say with trauma in general, just do the trauma work before you do more intensive PSB work. That's just kind of your take home. And last but not least, your zombie killing name. Okay. I've been the Mad Double Tap. I appreciate your time today. I think we have a few minutes for questions. So, Jess, I will pass it back to you. And Jessica is Storm Knife. You nice, Jess.
I'll take it.
That
I
fits
like
you.
it.
Yeah, love it.
Well, I mean, I'm going to say on behalf of our participants, because I know in the next couple of seconds they're going to flood through and thank you in the comments. And I know we're going to see a lot of these emojis scroll through. If you have a question, and I believe that many of your questions were answered actually in the chat. If there was one in particular and you want to drop it into the Q&A feature, we can take a look at that. But what I do want to say, again, on behalf of our participants today, Dr. Gomez, is we're so grateful, not just for the content that you brought, the energy you brought it with, but we understand this is a very delicate and difficult conversation. And I find, and I saw it in the chat, like I'm seeing it now, you made it approachable, easy to understand. And we're just grateful for that. And always grateful that you're here. And I saw someone say, I want to come to all Michael Gomez trainings. I was like, us too. And there are some replays actually in the Caltrin archive. So we want to remind you of that. If you go to caltrin.org, we have a training archive with a lot of replays in there. So I'm just going to take a look at the chat to see if there are any specific questions. Someone did actually ask, what is Target? I'm not sure if
Target is a model developed by Julian Ford and Rocio Chang at Connecticut. And it starts with trauma affect regulation, guide for education and treatment. Really what it is a very short term, it can be as short as 4 sessions, focus model for transition age, meaning 16 to 24-year-old kids. I apologize, you're 24, you're a kid. Okay, you're not an adult till your pupils are by life. But a lot of our kids in juvenile detention, things like that, our kids with like addiction, it's designed to be a stabilization, a very short-term therapy that works, that's designed for complex and developmental trauma. And so if you hijacked by your brain is the easy entry point to that. If you type that on Amazon, you'll get Julian's book there.
Wonderful. Thank you. And one last question. I thought this might answer some questions that people were thinking. Any recommendations on how people might check in or be mindful that their own bias or trauma is not affecting how they're helping?
Yeah, kind of 2-part answer to that. One is sometimes the term transference and countertransference still gets used. One of my mentors said, both of those terms, transference and countertransference, the reason they exist is if you're not aware of it. So the first step is if you're aware of it, you have such an advantage than if you're not. Just like anyone knows the implicit bias research that kind of gets that point hammered home. But the second part of this is secondary trauma, burnout, train. Like I do a lot of training in that. The model I use is CSERT. Brian Miller is the developer of the CSERT model. I think he's taught for Caltrain before. He taught me this. He developed the model. It's not self-care. We don't think self-care is super effective. We would like you to get cupcakes. Please get some cupcakes. But we don't think that's going to address like the 16 suicidal kids you saw this month. Oh, and yeah, I'll type I'll type hijacked by your brain. That's Julian's one. Really just the target one is actually very consistent with a lot of stuff Dr. Miller talks about. And so, because also Dr. Ford is not trying to tell you to calm down or to relax, because if you've ever been told to relax when you're pissed off, that person deserves a throat punch, and I'll go to bat for you if I'm like me and Jess were talking. It's weird how he started choking. Odd. And so we need much more robust kind of approaches to this. And Julian's model, Target, also Brian's CSERT, I think are much more robust. And so I'd start there because we do a lot of work in that in the trauma world, but we also do a lot in the PSB world.
Wonderful. Thank you so much. And someone did ask if there is a certificate for today's training. We are going to drop into the chat for you an evaluation. Thank you. There it is. This survey will give you access not just to share about your experience today, access a certificate of attendance, but also if you are applying or if you're interested in CEUs, there's information in there as well. And with that, we're going to end right on time. And again, Dr. Gomez, we're so grateful to have you here. So grateful to have you as a presenter, and we can't wait to see you again. So have a wonderful rest of your day, and have a wonderful rest of your day as well, participants. Stay on the lookout for the 2-day follow-up email that will come with materials, survey information, and all the good stuff. All right, everyone. Have a great rest of your week.
Thank you, folks. Take care.
Thank you.